Well, hello everyone. Um, I'm here to do your presentation for the musculoskeletal system. First, we're going to talk about some body mechanics, proper alignment, what are some variables with alignment and mobility in people, effects of exercise, and then how to assess the musculoskeletal system, although we know how to do some of it. This one will go more into detail. In addition, we're also going to talk about range of motion and the different types of movements that we do, and whether it's active range of motion um, or passive range of motion. Gosh, I couldn't think of the word. And then we're going to go through how we use the nursing process with the musculoskeletal system. So a quick refresh of the musculoskeletal system. So think about like everything you learned in anatomy and physiology. And I know for some this might have been a very long time ago. So just maybe look back into the systems if you still have your old books and kind of figure out what these things are. So understand the types of joints we have. So the hinge joint, ball and socket, that's like our hips, pivot joints, so those are the ones that can rotate, condyloid, saddle, and gliding joints, which all play a huge role in how the musculoskeletal system works. Further, we have the types of muscles. So we know the smooth or visceral muscles, those usually are muscles that cover things like organs. Skeletal muscle, that is, all of our pretty much the meat and potatoes of our body. It is, when we see those very strong gentlemen, like the Arnold Schwarzeneggers and who have like insane huge muscles. That's what I think about when I think about skeletal muscles. And then cardiac muscles, which is the muscles that make up our heart. And then think about what do our muscles do? So our muscles maintain our posture. They provide cardiac contraction, heat production, movements. Some are the walls of organs, vessels, and tubes. So muscles and bones are, make up a lot of our body, and we use it for a lot of the things in our body to live and just be. I don't think we think much of what our bones and muscles do. I do like to think of every time that I do this lecture, I think about when I'm going and making my lectures and how I'm always humped over because that's my posture. It's not good posture. And we're going to talk about that because we really do need to have proper body alignment in order to be able to provide care. So, body mechanics. We, went over some of this in our boot camp lab or our skills day lab. We talked about assuring proper body alignment, good posture. I'm sure while you guys are listening to this, some of you are not sitting up because even when I'm doing this, I'm not sitting up. I don't have the best posture. Good body mechanics provide optimal musculoskeletal balance, and proper body mechanics prevent injuries. Not just our own body mechanics, but for patients and what is optimal for them. So we have to understand our own body mechanics in order for us to understand the body mechanics of our patients. So good body mechanics, I've said you need to develop good posture. Yeah, I feel attacked because my posture is terrible, but I try. But we do need to have a pretty good understanding of how we stand, and also knowing that the longer we are humped over or arched over, and it just provides so much strain on our back. A broadened stance, so that's that shoulder width apart stance, so that you have that balance. Know your center of gravity. So I believe everybody has different perspective of their center of gravity. We've heard people who are top heavy and others who are bottom heavy, but we figure out how our center of gravity is so that we maintain our posture and our alignment. When lifting anything, work closely with your objects. So that's just, you've seen those pictures of people who are hunched over picking up things, using and straining their backs instead of having those boxes close to them and then moving them. Work on a clean, dry, smooth surface. That's just, we need to make sure that we're not going to slip, we're not going to slide when we're moving things. Instead of lifting things, like slide them, roll them, push them, it's much better for our body that we don't lift things. Learn to use your big, strong muscles. So don't use your back to lift things. I know that's easier said than done, but use your big muscles, your arms, your thighs, legs. These are big muscles, and using those, your core will help you prevent back injuries immensely. Flex at the knee, so bend at the knees, and use weight of your body as a force to pull or push, or use rocky motions in aid in movement. I like to explain that one as when I'm moving a patient, I tend to kind of use my body, and it's hard to explain. I can show you in lab, but pull the patient without using my back or anything, but using my weight and then moving them. It's very helpful. I learned that from an instructor many, many years ago, and I've used it in nursing, and it has helped in preventing me using my back when I'm moving my patients in bed. And it helps maintain a good alignment and prevents a lot of injuries. So body alignment and mobility variables. This is in your book, and it's pretty straightforward. So developmental considerations. Well, we know that a newborn, their body alignment and mobility would be quite different than somebody that is 80 years old. We know that a person's age and degree of neuromuscular development will influence their posture, their body, their movements, and their reflexes. Of note, and we don't think about this a lot, but for our musculoskeletal system to work, we need also our neurological system to be intact, because we know that people will have issues with alignment, mobility, if they also have neurological issues. So physical health, well, we know that if somebody is having problems with their nervous system, I just said that they may have issues with body alignment and mobility. which also includes that they can have issues with completing their activities of daily living. So other things are if they have like a fracture or a broken arm, things like that, we know those will have issues with body alignment and mobility variables. Musculoskeletal and nervous system problems. So congenital problems such as issues with bone tissue formation, osteogenesis imperfecta, which is a genetic disorder, nutrition problems like vitamin D deficiency or calcium deficiencies that lead to things like osteoporosis. Age-related problems, osteoporosis. And problems that involve other systems. Well, we know that trauma in the musculoskeletal system would have a great effect on body alignment and mobility. The central nervous system, so think about strokes or head trauma, cancers in the brain or the nervous system, and how that would affect body alignment and mobility. Mental health, well, we know that people who are depressed or anxious or even mental health disorders such as agoraphobia, where people tend to not like leave their house, we know that's going to have a great effect on their alignment and mobility. Their lifestyle, so we see this a lot. This is modifiable, but we know people choose lifestyles like smoking, not exercising, bad diets, things like that. Attitude and values, that kind of goes in with lifestyle, but some people don't believe in exercising. Some people don't find the value in exercising or eating healthy. Fatigue and stress. Well, if we're fatigued and stressed, we tend to not care of how we're moving, how we're doing things, or we might be so fatigued and stressed that we are trying to hurry and do things. Therefore, we might misalign our body. We might have mobility issues because we cause injury because we're not using good body mechanics. External factors could be things like weather. People don't want to exercise in 110-degree weather here in Arizona. Those are external factors that we really can't control. So exercise and immobility. How does exercise affect our body, and how does immobility affect our body? Well, we know exercise is an active exertion of muscle involving the contraction and relaxation of muscle groups in termed exercise. We know it's necessary for healthy functioning of the body. How does exercise affect our cardiovascular system? Well, it increases the efficiency of our heart, decreases our resting heart rate and blood pressure, increases our blood flow and oxygenation of all body parts. Respiratory, so increases the depth of respiration, increases respiratory rate, increases gas exchange, increases rate of carbon dioxide excretion. So these are all good and positive effects on exercise on the body system. The gastrointestinal system, well, when we exercise, it definitely increases our appetite. I know when I go for long runs, I can eat about 6,000 calories, which is probably not helpful, but that's the truth. Our intestinal tone, so we would digest faster because we are making our body work. urinary system is increase blood flow to the kidneys, helps maintain fluid and acid base balance, and increases the efficiency of our body getting rid of waste. For musculoskeletal, well, it increases muscle efficiency. We get stronger the more we use it. We get coordinated, and increases how the nerve impulses are transmitted in our body, which I found that pretty interesting, but makes sense. Our metabolic system, so that can be efficient regulation of our temperature, but it also can help insulin production and resistance decreasing. The more you exercise, the less issues you might have with blood sugar, so preventing diabetes and things like that. Our skin, so it improves our tone, color, and turgor due to the improved circulation. And then our psychological well-being, so we know that exercise is good for us. Exercise, our body produces endorphins, and it helps us sleep, improve our self-concept, and then we have positive health behaviors. On the flip side, immobility, so like not moving in terms of health, it is when a person does not move or only moves when necessary, but very minimal. We know immobility equals high risk health issues. How does it affect the body? So immobility will increase our cardiac workload. It increases the risk for orthostatic hypotension and the risk for clots, so venous thrombosis, so deep vein thrombosis that can turn into pulmonary embolisms. Respiratory, well, when we're immobile, we're not breathing as deeply, or our breathing slows down. Our secretions pool. There is some impaired gas exchange. You'll understand this when you go through your block 2 perioperative sections. Respiratory is a huge contributor of illness when people have surgery. And that is because of immobility. So even if somebody is having minor surgery, we encourage things like deep breathing, using the incentive spirometer. Those simple things are highly likely ways of preventing comorbidities when somebody is immobile or has surgery, and prevents pneumonia and atelectasis, which is basically a collapsed lung. Immobility affects your GI system, so disturbed appetite, which you might eat up more, altered protein metabolism, altered digestion, and decreased peristalsis. So people who are immobile tend to get very constipated, and then they tend to have a lot of GI issues. With urinary, so you can actually, being immobile will increase your risk of kidney stones. With the musculoskeletal system, immobility causes decreased muscle size, tone, and strength, decreased joint mobility, flexion, bone demineralization, decreased endurance and stability, and increases the risk of contractures. So contractures are those things where a person who is very immobile keeps their body in a certain way for long periods of time, that their muscles kind of stay stuck that way. and almost likely that muscle doesn't ever really get better. So, and it's very, very painful for people who get contractures who shouldn't have gotten contractures. Um, Metabolic system, so it increases the risk for electrolyte imbalance, and it alters the exchange of nutrients and gases. For the integumentary system or the skin, well, immobility is the number one cause of skin breakdown. So think about that. That is all your pressure injuries in whatever bony prominence, joint, or place. Immobility is the number one cause of that. And the way we fix that is making sure our patients are moving. Psychological well-being. So when people start becoming immobile, whether it's from illness or whatever the issue is, people start getting a sense of powerlessness. Decreased self-concept, decreased sensory stimuli, altered sleep and wake patterns, risk for depression, risk for learned helplessness. And just know, with exercise, there always is a risk, especially if you're not doing it correctly, it's not under supervision. You can have risk for injury. If you're exercising for the first time and you're not under the care of a physician, you might have heart issues that were undiscovered, things like that. The book does go more into details for the risk of exercise. You just need to know the basics. So how do we assess an interview for the musculoskeletal system? Well, just go back to what you learned in your physical assessment, health assessment stuff. So apply your basic interview skills. You're going to ask your patients, do you complete or do all your activities of daily living independently? Do you bathe yourself? Do you brush your own teeth? Are you able to climb stairs? Do you use mobility devices? Do you have any mobility issues? Are you having any dizziness, dyspnea, shortness of breath? Do you ever feel like your heart is pounding when you walk short distances? You can see a complete guide of what questions you would ask when interviewing a patient and collecting data. Focus assessment would be for the musculoskeletal system. Well, you would do mobility status, ease of movement, gait. If you don't know what the word gait means, gait is the way a person walks. And body alignment, and you'll assess muscle mass, tone, strength, endurance, the patient's ability to stand, walk, and even sit, even walk stairs. The way we do tone, strength, and all that is, when we're asking our patients to pull, push our hands, or to grip our fingers, that's assessment of the musculoskeletal system, but it also is assessing the I just forgot the name of it, the neurological system, because we want to make sure that it is done equally bilaterally. When you're assessing those things, we can assess patients, are their movements purposeful? So are they jittering or fidgeting, things like that? Because sometimes certain kinds of movements, like fidgeting, are not purposeful for any reason. I'm not saying like when you're sitting and you're like shaking your leg, because that's kind of something that a lot of people do. That is not an unpurposeful movement. But you'll see in the book and all the things you can assess for the musculoskeletal system. So what is range of motion? So range of motion is just how our bodies move at our joints, and how we're moving them. So the list of words and then the joint movements below are how we will um, assess range of motion of our patients. And just remember, there's active and passive range of motion. So active range of motion is when your patient can do it by themselves without you helping them. Passive range of motion would be when you assist your patient in doing range of motion exercises because they either have weakness or are unable to do it themselves. Like think somebody who might be a paraplegic or quadriplegic who have no ability to move. So then we provide that passive range of motion. So to prevent muscle wasting. So abduction, adduction, flexion, extension, dorsiflexion, plantar flexion, internal rotation, and external rotation are all range of motion activities, and you will need to know what these are, just because if you get a question on your test that says, I am providing passive range of motion to my quadriplegic patient and doing adduction exercises of the arms, how would the client's arms be moved? So I do recommend watching the range of motion video in the Lippincott page. I did assign it to you guys in Lippincott, so you have access to it anyways, but it's there, so it's easy to find. It'll show you exactly what each range of motion is, and you'll be able to see the pictures in the book as well. We will go through them in class. What do we do when we see falling patients? So if you're ambulating a patient, with your gait belt, and for whatever reason this patient either faints, decides to fall, we tell everyone not to prevent the fall. The fall's going to happen no matter what. The only thing you can do, if you're able to do it, is ease your patient down to the floor. And we'll watch some videos in class about how to do that. I think the pictures are kind of funny. They look funny to me. But learning to ease your patient from falling, you can use your leg and almost use your leg as a slide to get them down to the ground where they're not actually like thunking down, because that would, prevent injury. All right, so add pi. What is that? I'm just kidding. So with the musculoskeletal system, we could go through the nursing process. So musculoskeletal system of an immobile patient. So what are some things you would assess? So you would assess their movement, their pain, skin color, sensation, skin temperature, pulses, range of motion, whether it's active or passive, cap refill, the Braden scale, the Morse-Fall scale. We'll talk a little bit more about those two assessments. So the Braden scale is just an assessment that we do for people who are at high risk for skin breakdown. And then the Morse-Fall scale is another assessment we do on patients that gives us a number that is assigned to how likely they are to have a fall while they're in the hospital. It takes into account their history of falling, any disease that might hinder their thought process, if they are attached to anything like IV poles or the sequential devices for the compression devices and things like that that might cause falls. But those are just some assessments that we can do for a musculoskeletal immobile patient. And then with our assessments, we can start creating a problem or find a problem that needs to be identified. And just some examples here are pain, impaired physical mobility, risk for impaired skin integrity. Planning and outcomes would be, you would prioritize based on your patient's needs. ABCs, the Maslow's hierarchy. Example for this one, let's say our nursing diagnosis is pain, so patient will report a pain of 4 out of 10 on a numerical pain scale by end of shift. What's the implementation of this plan? So what are you going to do? What are the interventions? So administer medication, provide distraction, reposition the patient, check vital signs, assess skin, things like that. And then you would evaluate. So patient reports pain 5 out of 10. So goal was not met, goal modified. And then you reassess and start over. This is just a basic example. Know that with each disease you're going to learn, or I should say not disease, but like your fractures and things like that, your nursing process will change based on what the thing is. So like if it's a fracture or if it's osteoporosis, what would be interventions for that and things like that. Those are things we're going to go over in the class. So be prepared to work through some nursing process for fractures, osteoporosis, and things like that. All right, you guys have made it to the end of the musculoskeletal slides. I'll see you next in the sensory slides. Thanks, bye.